Ah, okay. Plain LAO, come to plain LAO. What is the creatinine like? Okay, give us the wiper wire. We'll try direct wiring with wiper wire. Okay. ഒരു LAO, plain LAO view. കുറച്ച് blanks ഇനി and then this view we'll try wiring. So basically this patient, he had undergone a bypass surgery almost 8 years ago. Now presented with recurrent rest angina. The lima to LAD is working well, and rima to the circumflex territory is working well, but then the rima which is connected to the distal PD has got occluded. So primarily now we are trying to open up the critical lesion in the mid-right coronary artery, which is calcified. It appears to be significantly calcified, but angiographically it looks more like a deep calcium rather than a superficial calcium. If you could see the lumen and the calcium appears to be a little bit away from the lumen. So most probably it appears to be deep calcium, but then we decided that we'll do a calcium modification, and then okay, we can take the other. Okay, we'll go with this. Okay, so after calcium modification, we'll do the imaging and see what exactly is happening. So that's now because it's not a very difficult lesion, we thought that we try wiring with the wiper wire itself. The guide is out. Okay. Oh, we are directly wiring with the wiper wire. It's Coetanox wiper wire. Still we are able to manage it, which we just can't imagine with a rota wire. It's not good. No contrast. Now small contrast, small test. Okay. Okay, now the wire is across. Now the backup support is quite poor. Should we change over to a short Amplats catheter now itself? Because the orbital would certainly not, just like that it won't cross. You'll have to do some pushing also. So with such a bad backup support, if you try to do that, may not go in. I think it's better that we go with a short Amplats left catheter. We take out this wire, or we can leave that wire there. We'll keep the wire there, remove the guide catheter, and then take a short Amplats catheter. AL 0.75. Okay. See, I'll hold on to this. You keep pushing the wire. Loop വേണ്ട. Now give us short Amplats. Loop should be there. Push little bit. Okay. Okay, small loop. Okay, we are out. Now give short Amplatz catheter. I'll hold on to this. Okay, SL catheter. SL catheter, then the Y connector. The introducer needle also for the Y connector. Then we'll have an O35 wire also going through that. Put an introducer needle into that. Take it, disconnect it. Put an introducer needle and then through that wire. Okay, okay, that's good. We initially tried engaging with the Jenkins catheter, and again the backup support is not good. The wire went in, but we may not be able to get any backup support with that for pushing the balloons and all across. So we thought that we'll switch over to a short Amplatz catheter. Hold on to the wire. Now, okay, now get a O35 wire also through this. I'll hold on to. No, just because the wiper, wait, Ashwini, just because the wiper wire went in, okay. Give O35 wire, it's not going in. Show the catheter tip, show the catheter tip. Okay, now show the LAO view. Okay, we'll take out the O35 wire. Okay, now get ready with the orbital device. No, don't inject. No, it's totally here. Okay. Okay, now give us the device. Centralize. Okay. So we are going with the device. We'll check all the parameters. Make sure that the switch is actually the on-off button, toggle button is towards. Okay, we'll release this. Okay. 1 inch proximal to the most distal end of the groove. 1 inch proximal. We lock it. It's now unlocked. 1 inch. Okay. Okay, now we'll check this. Check the bar. There is no air bubble in that, right? Please check it. Fill the column. Press other chamber. Okay. Okay, now we'll go in. Pressures are okay. Yes. A single operator technique would be the most easiest way of managing that. Rotabar, most of the times it wouldn't go with this ease. Okay, we are ready now. switch, lock on. Oh, that went in without any difficulty. So primarily it's a deep calcium. It's not an intimal calcium. Be ready with atropine also. We were made to understand that while doing orbital, you really do not need a temporary pacemaker. But we would, in our experience, at least 50% of people during RCA, orbital atherectomy, they do develop brady. So it's always safe that we go with a temporary pacemaker also. No, here we'll see the OCT image. Yeah. Getting across the lesion, and we would have done justice with this orbital otherwise. See, the orbital crown is actually away from the calcium, so it looks. See, probably we'll do one more run at higher speed and stop, because there is no significant change in pitch. Pitch was not significantly changing. It went in without, despite being a very critical lesion, it went in without difficulty. So it's likely to be a soft plaque, and the calcium is too much of adventitial calcium rather than a superficial calcium. We'll wait for 10 more seconds, do a run at 120,000 RPM, and then we'll do the imaging. Yeah, it's a nitinol wire. The tip is hydrophilic. വേറൊരു ഗ്ലൗ തരാമോ? Enough. Brady. We'll come little more proximal. Yes. I think we'll come out. Okay. So I'll keep pushing the wire. Okay, you can switch it on. Release, open the Y connector. Now we'll go with the imaging catheter. Prior to that, we'll give some nitro and take an image. Okay. Nitro, run through wire, and OCT catheter. And they also say that if at all you develop a brady, even you don't need a temporary pacemaker. It may not be a prolonged brady, but that's true. Most of the time, within few seconds, it settles down. Yeah, even without atropine, most of the time it settles down. But then you'll be more comfortable when you don't see a lot of bradycardia. So. Yes. Based on the wire bias. Can you ask them to reduce the volume little bit over here? Yeah. Unless you are into the adventitia, you are unlikely to perforate it, no? Did we take a shoot? It looks like a huge vessel. It's a huge vessel. Ask them to call them over here. നിങ്ങൾ ഇടയ്ക്കിടയ്ക്ക് വോളിയം കൂട്ടുകയും കുറയ്ക്കുകയും ചെയ്യുന്നുണ്ടോ? ചെയ്യരുത്. ഇപ്പൊ ഒന്നും കേൾക്കുന്നില്ല. തീരെ കുറയ്ക്കാണ്ട് പറഞ്ഞാൽ അത് ഭയങ്കര ഒച്ചയായിരുന്നു. we take out the wiper. ഹലോ, ഇത് ഒത്തിരി കൂടിപ്പോയും വേണ്ട. It's too much. We'll reduce the volume little bit. Okay. So now the luminal gain is quite good, angiographically at least. Now we'll do an OCT imaging. We are ready with the OCT images. Purging has been done. 20 cc syringe. And the creatinine is good. Okay, that's enough. Okay, we are ready. Yeah. Okay, auto calibrate. Oh, yes. Activate. Okay. Now shall we go with a 3 or a 3.3 balloon for dilatation? Sini will take this out. I'll see the images. In the pocket in mobile. So now distally we'll do the co-registration. എന്തെങ്കിലും പറയണോന്ന് ചോദിക്കേ. Three balloon. We'll use 3. Well, now as we go distally, angiographically, this area seems to be a reasonably good zone. So we'll check the vessel size over there. And again here almost we need to see 180-degree arc of normal vessel. That is 3 layers of vessel. So we are almost seeing one or three layers from here till here. So this particular area would be the ideal place to assess the length. Almost 3. So distally it appears to be 3 millimeter vessel, and then as we come proximally, this is more of fibrotic plaque, some amount of calcification there, and these are all islands of calcification. No significant 180-degree or more than that. Here it appears to be a little bit less than 180. Yeah, one quadrant. And as we come more proximally, here again the lumen looks good, the vessel looks good. And now we are reaching the area where we did the orbital atherectomy. Yeah, it looks more of a fibrotic lesion over here. There is some amount of lipid also over here. These are all lipid pools. So basically he had an ACS, so it's more of a lipid pool, and whatever calcium, it's all distal, that's deep calcium. So probably orbital didn't do much for him, and this area probably this is probably a macrophage over here. When you see this dark bright area followed by a dark looking this particular thing, that tends to go in favor of macrophages. And then as we come more proximally, the vessel appears to be a much bigger vessel. It's almost 5 millimeter over there, and here the lumen is around 6 millimeter square, 8, 9. So I don't think we need to come till the ostium. At the ostium, it's almost 7 millimeter square. So we'll stay well inside the lesion only. From there, we'll stand downwards. Angiographically, that area looks reasonable. So from there till the distal landing zone, this would be a reason. So it would be around 44. So probably we can go in with a 48 millimeter stent. 48 millimeter stent, a 3 and then 3.5 for post dilatation. Sini, we have done pre-dilatation, is it? It didn't cross lesion. Then we'll go with a New York one. ICU admit, yeah, manager. Then we'll take a New York balloon. It didn't cross. But the OCT catheter went, and it's an ox balloon. Okay, we'll 312, yes. Three distally, proximally it's almost 5 millimeters. So at least we'll do a 3.5 more proximally, 3 distally, and then do an OCT imaging. If needed, we'll further optimize it with a 4 millimeter balloon. Yeah, that's. We had a good area wherein we were able to see 180-degree arc of normal looking vessel. So 3 layers were very clearly seen. I am basically always very conservative. See, even when we see a 4 mm vessel, I'll be satisfied with the 3.5 post dilatation at 1820 atmosphere, because 3.5 and 4 mm lumen wise, you're not going to have a huge difference. In the second generation, this particular generation, a 4 millimeter and 3.5 lumen, it's really not going to make a huge. Ultimately, we wouldn't want to have a perforation, things like that. That's number one. Secondly, it's always safe. We saw that it's a 3 mm vessel distally. You can always take a 3.5, deploy it at lower pressures. The safer option would be 3 and then further post dilated. That we post dilated, pre dilated it well. We'll take a small check and then go with the stent. Kanilaya. Okay, it's fully opened up. Now the stent. One second, don't open it. Shall we stent it from down there? So then won't we need 2 stents? 48 will it cover till that particular area? And OCT wise, we saw that it would, from there to there is only 48. I think we should believe OCT. Give yes, 348. that particular area, just beyond the lesion. Be ready with a guide extensional catheter also. Okay, okay. Now we'll push the wire. Okay, okay, that's enough. Okay, I think we'll have to come back a little bit. Shall we come back 2 millimeters and then do a cine? Okay, okay, we'll do a cine now. Distally, do we really need to go till that particular area? It's safer, huh? Little couple of millimeters proximally shall we come to aleocranial, just 2 millimeter proximal. 2-3 millimeters. We'll cover the proximal lesion and decide if something needs to be done distally. 2-3 millimeter. Anywhere. Okay. Okay, we do a cine. I think we'll go up 14, 16. 14, 16. Yes. Yes. Negative. Give 3, 3.5. Yeah, 3 and 3.5. 3.5 and then OCT imaging, and then decide whether we need to further post dilate with a 4 mm balloon. Okay. 3 and 3.5. If you want, you can dilate it there and then further push it distally. Dilate. 14, 16, 18 and then further push. Negative. Yes. Yes. 14, 16 and 18. Negative. Is it 3 LA? Okay. Okay. 18. Negative. 18. Now we'll go with a 3.5. Okay. Proximally kuda cheyasini, otherwise the 3.5 balloon may not go through because it's ox. Okay. Okay. 18. negative. We'll take a small puff before we take it out. Okay, that's good. Yes, 14, 16, 18. We have another 2 more cases. 7:30 we'll have the session over there at Indraprastha. So now we should be done in another 10 minutes. Would you want to go after this case, take rest and join 7:30? That will be better, no? Because we have another 2 more, we'll finish it off. Yes, we'll go up. 12, 14, 30, negative. Small tessini perforation. Okay. 14, 16, 16, negative. 16, negative. Small test. Okay, we'll go up. 14, 16 and 18. Now we'll see an OCT image and then decide what more to be done. OCT ready? You wouldn't have slept properly also last night, right? Okay, that's good. You're ready? We would want to see if there is any distal dissection, whether the proximal stent is well opposed or not. Yes. One second. Hold on. Cancel it. We are actually inside the stented area. The distal end is not beyond the stent. Once again, live view. Show the live view. Live view. See, you're seeing the stent struts there, right? So we need to go a little more distal. Okay, that's good. Yes. Activate. Very good. Distally, there is no dissection. Proximally, we need to further post-dilate it, isn't it, Sini? See, distally, beyond the stented area, there is no dissection. And now, if we can once again evaluate the vessel size, initially we felt it was around 3, now it's more than 3. Now it's more than 3. Now the lumens are good, 6 millimeters square. Here it's 6.5. As we come more proximally, 7, 8 millimeters. And there is nothing floating into the proximal segment. It's all well opposed. 8 point lumen is quite good. This particular area, we saw that there are few struts that's not well opposed. The area where we saw that particular lesion, the area of the tightest lesion, there are few struts which is not well opposed. This particular area, anything less than 400 microns, you can 220, 260 microns. Probably we wouldn't have to do anything for that.